Great. So, good afternoon, everybody. I hope everybody can hear me and see my screen. Can I just get confirmation from you, Matthew?
It's just in thinking mode still. We're just getting one of those little
let's see if
dials. So it looks like it's trying.
Okay, is it a connect maybe from the long distance to Vancouver? Can anybody else?
I can see your screen, Prof. The first slide.
You can see the first slide. Okay, great. I'm going to start. Thank you very much. So a big welcome to everybody. And today, once again, a very exciting deep dive. We've got a session on transfusion. And we've got no one less than Venita Rumberich from the South African National Blood Service that will be talking to us. And I will let Prof. Matthew Seftel introduce her in a few moments. But just by way of housekeeping, just to let you know, now let's just see if I can get this to the next screen. Oh, too far. So just to let you all know that recordings are available at UCT's VULA platform. If you have any questions or answers to comments made, please add them to the chat. We really invite everyone to collaborate and contribute and give us ideas and thoughts and questions. There will be some time for live discussion as well. So if you want to prepare your thoughts and questions, please do so. And then there will also be a link at some time point, probably just after 5 or nearing the end, where you can fill in your CPD survey. It takes about 1 minute or less, just to make sure that we've got your details. And if you need CPD, if you don't need CPD, don't worry about it. But it's still nice if you want to register your attendance. That helps us to just put together the data that we need in terms of seeing how deep dive develops. So with that, I also am very happy to introduce Matthew Seftel. Matthew is ex-UCT, University of Cape Town graduate, who is currently in Vancouver, Canada, and works at the Canadian Blood Service. And Matthew is also an honorary professor at UCT and a great collaborator and team member on the deep dive. And Matthew, wonderful that you were willing to chair this afternoon session. And we look forward also to your inputs and thoughts on the things that will be discussed. I'm going to hand over to you, that you're welcome to introduce Venita and then continue, take us from there. I'll be in the background and also be available to share the polls when we get to that point.
Thanks, Vernon, and good afternoon or evening to you all there south of the equator. It's good morning here from Vancouver, very early morning. So I think that blood transfusion is always a useful topic to cover and then recover from time to time. I think, as everybody knows here, it is a medical intervention or a therapy that touches, I think, virtually every aspect of medicine, and certainly hospital medicine. And even with respect to the donors who give their blood, it's the opportunity for healthy people to play a role in the medical system as well. So it's quite a universal technology. So we have a very fine example of somebody who's going to be speaking about general aspects of blood transfusion today. And I've had the opportunity to meet Venita Rumberich before through the Fogarty program. Venita is head of learning and development at the South African National Blood Service at SANBS. She's based in KZN. She is heavily involved in transfusion medicine education and training, as she is today. She has international connections through the AABB Global Transfusion Forum, and she is currently a PhD student at UCT through a Fogarty Foundation fund. And she is one of the key role players in the collaboration between SANBS and the UFS, aimed at developing online short learning programs in patient blood management for healthcare professionals. So Vinita, very warm welcome to you today, and thank you very much. And Vinita, you are welcome to start sharing your slides if you're available.
Sure. Thank you very much for that introduction, Prof. I'm going to share my presentation, and let me know as soon as you can see it.
We can see it, Vinita.
Okay, I'm just going to move to presentation mode. All right. Can you see my slides clearly?
Very nice.
Yes, excellent. Thank you.
Okay, thank you very much. Good afternoon, everybody. Thank you for the warm introduction, and thank you, everybody, for making the time to attend. So this afternoon, I'm going to be talking about transfusion basics. We're going to talk a little bit about cross-matching and blood group interpretation, and then I'm going to discuss with you a very interesting case study. Okay. All right, so our agenda today, I know it's the deep dive session, so we're entering the deep ocean, but we're only entering the very shallow phase, just a foot in probably. So I think it's important that we keep our life jackets on, because all parts of the ocean, when it comes to transfusion, are potentially dangerous. So today we're going to talk about the basics of transfusion testing. We're going to talk a little bit about incompatible cross matches and the challenges they present. Of course, we have to talk a little bit about patient blood management, because we cannot talk transfusion without PBM. And then I'm going to go through an interesting case study, as I mentioned. Okay, so starting off, just to talk about the fact that blood transfusion, we all know it saves the lives of patients every single day. However, it does come with a whole host of risks, and those include transfusion-transmitted infectious diseases. We have the challenge of alloimmunization. So when patients do get transfused, they're exposed to red cell antigens, white cell antigens, platelet antigens that they lack, and they can in fact produce antibodies to those antigens that they lack, and these can actually compromise their future transfusions. And then we have the complications of the immune and non-immune type reactions in patients. Okay, so if we look at the blood service and the clinician from the clinical guidelines for the use of blood and blood products, we have this one statement which I think is very, very profound. It says that in the broad doctor-patient relationship, the doctor and the blood service both owe a duty of care to the patient, and both are in a unique position to prevent harm. And I think this is really important, because the clinician, who is the ultimate decision maker in terms of whether the patient requires a transfusion. Okay, let me just continue. Yes, so the clinician, being the transfusion decision maker, makes the decision whether the patient does require transfusion, and then he needs to weigh the benefits and the risks, and determine whether transfusion is warranted or not. And then the blood transfusion service, we have an obligation to make sure that we collect the safest possible blood from our donors, and we do all of the relevant testing to the quality standards to ensure that patients have safe transfusions. Okay, so the very first question I do want to ask you, because I know doctors order blood on a daily basis, but I do want to know is, do you know what happens to the blood sample and request form when it's sent through to a blood bank when you order blood for patients? So that's our first poll question for this afternoon. Okay, and the reason I'm asking that question is because quite often, we receive a request for blood and we're busy performing our testing, and sometimes doctors can't understand why it is that it takes so long in the blood bank. I mean, there's sometimes that assumption that we have a fridge full of blood, and when a specimen comes through, we do some sort of testing and then the blood should be readily available for transfusion, but it's actually not as simple as that. Okay, so if I look at the poll responses, we've got 53% that says yes, and 16% say no, they do not know, and 31% say somewhat. So that's an interesting response. So I think that this presentation today certainly is of value, because it's an opportunity for everybody to know exactly what happens in a blood bank, particularly in terms of transfusion testing. So I hope it's going to be a meaningful learning exercise. Okay, come on. There we go. Okay, so what is compatibility testing? Now, the terms compatibility testing and cross-matching, these are terms that are used interchangeably quite often. However, it's really important that we clearly differentiate these terms because they are somewhat different. So a cross-match is in fact only a part of the compatibility test that is performed to determine any serological incompatibilities that may result in decreased survival of donor red cells in the transfused patient. So it's only part of the compatibility test. So what does the compatibility test comprise? Firstly, the most important thing is checking of the patient details and making sure that we review the patient's transfusion history and records. The second thing that is important is the ABO grouping and the RH typing of the patient. We then perform antibody screening tests where we screen the patient's plasma for any irregular antibodies. Then, based on that, we select blood for cross-match. Then again, once we select our blood for cross-match, we ensure that the blood group and the RH type is correct. And then lastly, we actually perform the cross-match. And that cross-match procedure involves testing the patient's serum or plasma against donor red cells, and that is where we determine compatibility. So the compatibility test comprises a whole host of steps, and every single step is important before we actually get to the final cross-match. Now, checking procedures and transfusion history, that's extremely important. And as you would know that the blood service, the blood bank, we're extremely pedantic about checking procedures. So quite often you may send a cross-match request with a form, your specimen, and everything appears well. And then you get a call from the blood bank. And they want you to verify the patient details, be it a name, a surname, a hospital number. So what in fact happens is that when we get that cross-match request, we must check the patient's surname and first name, both on the form and specimen, and there must be 100% correspondence. The second important factor to check is the hospital number, and that too must have 100% correlation between the form and the specimen. We also check the previous transfusion history. And then lastly, we check the order, basically what it is that the doctor has ordered. So there are a whole host of other checks that we do, but primarily these checks are extremely important, and we must get consensus and clarity and clarification from the doctor to make sure that the form and specimen that we have received in the blood bank belongs to the same patient. Only once that happens, we receive the sample and the form, we attach a unique barcode label, and following that, once we register this cross-match on our electronic system, we are able to move on to the actual testing process. All right, so if we look at the testing process, we start firstly with the ABO blood group. So if we look at the ABO blood group, we're looking at two aspects of testing. One is called the forward group and one is called the reverse group. Now, ABO blood grouping is actually quite simple, but it can be a little complicated if a patient does not fall in one of the routine categories, if I may put it in that way. So if we look at the ABO blood group system, there's in fact just two most important antigens. There's two antigens, in fact. One is the A antigen. So if you have the A antigen, you are blood group A. If you have the B antigen, you are blood group B. If you have both A and B antigens, then you obviously group AB. And then if you lack both A and B antigens, then you are blood group O. So when we do the forward grouping, that is exactly what we are looking for. We are trying to identify what ABO antigens you have on your red cells. And to do that, we test your red cells, which are unknown to us at that point, with known antibodies. So anti-A and anti-B. And antigen antibody reactions, they are very specific. So anti-A can only react with A antigen, anti-B can only react with B antigen, and simply that's how it is. So interpretation is usually quite straightforward. So that's the forward group. Once we identify the antigens on your red cells, it gives us an indication of your blood group. But we don't just stop there, we do the reverse group. And why we do this reverse grouping, where we test a patient's plasma for corresponding antibodies, is based on the fact that there is a uniqueness about the ABO blood group system. And Karl Landsteiner, who discovered the ABO blood group system, he identified this unique characteristic that with the ABO system, if you lack a particular antigen, ABO antigen on your red cell, you automatically have, or you naturally have, the corresponding antibody in your serum. So to simply help everyone understand that, so if we look at a group A individual, you have A antigen on your red cell, you lack B antigen, so you naturally have anti-B in your plasma. Similarly, with the group B individual, you have B antigens on your red cells, you lack A antigen, you naturally have anti-A in your plasma. And that's how we do the interpretation. So in terms of interpreting the blood group of a patient, we determine the antigens on the red cells, the corresponding antibodies in their plasma, and once that correlates, we can confirm the ABO group of the patient. And these are the reagents that we use. Specific antibodies, they high quality monoclonal antibodies, and usually the specificity is so good that even if there's weak antigen on the red cells, we are able to detect them. So this table shows you interpretation of basic blood grouping for the 4 common blood groups. All right, then we're moving on to the Rh typing testing, and here again we're using a specific antibody reagent, which is anti-D, and here we are detecting the presence or the absence of the D antigen. Now within the Rh blood group system, there's a whole host of antigens, but the D antigen is the most important antigen of this system. It's the most immunogenic, and it's really important that we identify the presence or absence of the antigen on the red cells of an individual. Why is it so immunogenic? It is so because, one, the nature of the antigen, it is protein in nature, and secondly, it's actually a very large protein. It consists about 417 amino acids. So if you have an individual that's Rh negative that lacks this very large protein, that does become exposed to this big D antigen, this huge protein, the body is very likely to recognize it as non-self and produce an antibody, anti-D, in response to that. And it is known that approximately 80% of Rh negative individuals that are exposed to Rh positive transfusions are actually, in fact, most likely to produce anti-D antibodies. So that is why, following the ABO blood group system, Rh typing, particularly typing for the D antigen, is clinically significant. Okay, and then we move to the antibody identification test, and here we're actually screening the patient's plasma for any irregular antibodies that may cause decreased survival of donor red cells in the patient. So here what we do is we test the patient's serum against a panel of known red cells, 2 panels, 3 panels, depending what it is that the testing facility is using. So if we get the antibody screen negative, it means that the patient does not have any irregular antibodies, and we shouldn't have any problems with the cross-match, ideally. If the antibody screen test does come up positive, it is an indicator that the patient has irregular antibodies. It does not, however, tell us what the specificity of the antibody is. So we know the patient has an antibody. What it is, we have to investigate. Okay, so moving on to clinically significant antibodies. what are clinically significant antibodies? How do we classify them? Now, there's a whole host of antibodies. There's almost approximately 23 blood group systems with a whole host of antigens and corresponding antibodies. So what determines whether an antibody is clinically significant are certain characteristics. So one, if the antibody is IgG, it reacts at 37 degrees by the antiglobulin phase. If it is known to cause an unacceptably short survival of transfused red blood cells, if it has caused previous transfusion reactions, and if it's implicated in hemolytic disease of the fetus and newborn, these characteristics make that antibody clinically significant. And that is really important in transfusion testing, because when we identify a clinically significant antibody, we have to ensure that we match ABO and RH compatible as well as antigen negative blood for the antibody that the patient actually has. Okay, so if we look at antibodies that are regarded as always being potentially significant, we have the ABO, RH, CAL, Duffy, and KID blood group system antibodies. We have antibodies that may sometimes be clinically significant. So these are the antibodies anti-LEA, anti-M, anti-N. Now these antibodies sometimes can be IgM, 20-degree antibodies. However, sometimes these antibodies can have a wide thermal range, and if they're reactive at 37 degrees and if they're in the IgG form, then they do become clinically significant. And then we have these antibodies that are really, if ever, clinically significant. Okay, so when we look at the cross-match itself, remember the cross-match is actually matching the patient's plasma against the donor red cells. We always start the cross-match with an immediate spin cross-match, or we call it a saline cross-match sometimes. And here we do this to check for the possibility of an ABO incompatible cross-match. So sometimes maybe we've selected ABO incompatible blood for the patient, or we can identify whether the patient has IgM antibodies or cold autoantibodies. However, the cross-match that really matters to us is the antiglobulin phase cross-match. We call it the IAT or the AHG cross-match sometimes. So here what we do is that once we mix the patient's serum or plasma with the donor red cells, we incubate it at 37 degrees. It's washed 3 times in saline to remove any unbound substances. We add antihuman globulin, and then we check for the presence or the absence of agglutination or hemolysis. So here, if we have a negative reaction, it means that the blood is compatible and safe to issue for transfusion. However, if we have a positive reaction, like you can see in these particular pictures, it means that the positive reaction indicates incompatibility, and that is obviously an unsuitable unit of blood and cannot be issued for transfusion. Okay, this is just a table to show you how we actually match units of blood. So sometimes, for some reason, if a patient is a particular blood group, and like in this case, we have a patient who may be a blood group A, ideally we give group-specific matched blood. So if a patient is group A, we would give group A blood. However, for whatever reason, if we do not have group A blood, then these would be the alternate choices. We can use weak A or group O low titer. So you will always see here for all of the blood groups, group O is always an option. However, it needs to be group O, low titer blood. Why we say low titer blood as being the universal donor is because we can sometimes have the dangerous universal donors. Those donors are actually group O, but they have the immune forms of anti-A and anti-B, and those can be dangerous in terms of causing a hemolytic reaction in the patient. So if we use group O blood for a non-group O patient, we need to make sure that those units of blood are in fact low titer. Okay, so just to give you a summary before we move on in terms of what happens in the entire compatibility test process. So as I said, we check the patient details and previous transfusion history. We determine the ABO group and the RH type of the patient. We perform the antibody screen test to determine the presence or absence of any irregular antibodies. And depending on that, we select ABO and RH compatible blood for the actual cross-match. Once we get that, we confirm the blood groups of the donor units that we selected. We then perform the cross-match. We recheck all of our test results, and once everything is in order, we can issue the units of blood for transfusion. Okay, so sometimes it is not as simple as that. Most times we go through that entire process and we are easily able to issue units of blood for transfusion. However, sometimes we do experience challenges. So where does the problem start? Quite often, it's usually in the antibody screen test. So what happens is that when we screen the patient's serum for any irregular antibodies, most cases it's negative. The patients do not present with any irregular antibodies, but sometimes they actually do present with some irregular antibodies. And here you can see in this particular case, this patient is presenting with positive results with the 3 panels of screening cells. So this tells us that we need to actually identify what the antibody is. So as I told you previously, when the screen comes up positives, it tells us the patient has an antibody. It does not tell us what the antibody is. So when we proceed to an antibody identification test, here we test the patient's plasma against a panel of known red cells. In this case, you can see there's a panel of known 11 red cell panels. And when I say known, it means that we actually know the phenotype of each of these panel cells. So what happens is that when we test the patient's plasma against these known panel cells, we look for a particular pattern of reaction. And in this particular case, I've chosen a very simple one. As you can see here, this patient is showing a reaction in panel 3 and panel 6. If we have to match this reaction that the patient is, we are seeing with this patient's plasma, we can see that we can match it very clearly with this particular antibody, which is anti-E belonging to the RH blood group system. Here, anti-E presents with a positive result in panel 3 and in panel 6. So in this particular case, we can easily conclude that this patient has anti-big E. So in terms of cross-matching, what we would have to do is select ABO and RH match blood, and we need to make sure that the units of blood that we select for cross-match are in fact big E antigen negative. Okay, so sometimes we need to proceed and perform more testing to unravel our incompatibility problems. So we in fact perform the direct antiglobulin test and autoantibody screening test sometimes. So in a DAT, we know that this particular test detects in vivo red cell sensitization. And here what we do is we take the patient's red cells and we wash it directly in saline and we add anti-human globulin. This test actually can provide us with very useful information because it can link us to potentially what the problem is. So when we do get a positive DAT result, depending on the case that we are working with, it can tell us a couple of things. So one, in a cross-match situation, when we finding all of our units of blood incompatible, we perform a DAT on the patient sample and it tests positive. It's a possibility that the patient could have an autoimmune condition like autoimmune hemolytic anemia, where the patient produces antibodies against its own red cells. In the case of a transfusion reaction investigation, a positive DAT in a post-transfusion red blood sample can tell us that the patient has potentially been transfused with the incompatible red cells. And if it is a hemolytic disease of the newborn hemolytic disease of the fetus and newborn investigation, it can tell us that it's a likelihood that maternal antibody, IgG nature, has crossed the placenta and sensitized the fetal red cells with the corresponding red cell antigens. So that is very useful for us. It can point us in the direction of where the problem lies. So if we look at an autoantibody test, this too is an important test. So in this particular test, we test the patient's plasma against the patient's own red cells to detect the presence of autoantibodies. So we can identify cold autoantibodies that usually react at room temperature or in the saline phase. Usually, it's not that difficult to find a compatible blood in the case of cold autoantibodies. However, if the patient does have warm autoantibodies, finding compatible blood is usually a huge challenge. And sometimes the only blood that can be issued for transfusion is weakly incompatible blood. So obviously, under certain circumstances, that decision has to be made. But once we've identified that the patient does not have any underlying clinically significant antibodies. Okay, so if we look at what are the potential causes of incompatibility, one is ABO incompatibility between the donor and the patient, and we can easily pick that up through our testing. Sometimes RH incompatibility can cause a positive cross-match result as well. Then the common cause is usually alloantibodies in the patient's serum that reacts with the corresponding antigens on the donor cells. So here we can either have the patient presenting with a single antibody, or the patient could have a multiple combination of antibodies. Sometimes the patient may have an antibody to a low frequency or a low incidence antigen, or the patient could have an antibody to a high frequency or a high incidence antigen. Now, let's talk about these antigens. So low frequency or low incidence antigen is actually an antigen that is, in the case of a high frequency antigen, it would be an antigen that would be present in 99.9% of the population. So if we look at the low frequency antigen, that is not the problem. So if we have a patient that has an antibody to a low frequency antigen, finding compatible blood is not a problem, because almost everybody would be antigen negative and blood would be easily obtainable for this patient. However, when we have patients that present with antibodies to high frequency antigens, that's a huge problem, because a patient actually in this situation has an antibody to an antigen almost everybody has. So finding one particular or a few individuals that are actually antigen negative for this antibody is the problem. So sometimes we can screen all our donations in our blood bank fridge and we may not be able to find compatible blood. So that is why it can be a huge challenge. There would be delays in getting compatible blood for the patient. Blood cannot be ordered on emergency, and quite often in these particular cases, we have to consult our rare donor program. Okay, and that is a topic on its own for another day. Sometimes as well, patients have autoantibodies, as I mentioned earlier. Again, a whole host of tests have to be performed in these particular cases to rule out the possibility of autoantibodies actually masking clinically significant antibodies in patients. So that is why we can end up having huge delays sometimes in getting compatible blood to our patients, or getting the best possible blood to the patient. Other causes that are not as common, we have sometimes our donor blood can be sensitized for some reason or the other. We can have contaminants in our testing system, or there could be abnormalities in the patient's serum in the cases of certain disease conditions that the patients may have. Okay, so I just want to talk about this particular comment made by Professor James Spester. I think it's really, really important. So he states that transfusion of allogenic labile blood components, they are tissue transplants and they have the widest and most heterogeneous potential hazards, probably greater than any other medical intervention. However, this is not the message that is currently being communicated to clinicians, patients, and the community at large. And based on that, I just want to ask this particular question in my poll, which is actually there in fact 2 questions. So I do want to ask, do you take the time to explain the benefits and risks of blood transfusion to your patients? That should be a your and not you. Okay, so it would be interesting to look at the poll results. Okay, that's good. So to share with you the poll results, so 76% say yes, they do take the time to explain the benefits and risks. 5% say no, and 19% say sometimes. So that's an interesting response. It's good to know that the majority do, but it's a really, really important aspect to explain the benefits, risks, and also consider alternatives in terms of what is best for the patient and looking at each individual patient in their own unique circumstances. And then the next question that I do want to ask is, do you consider alternate approaches to correcting anemia rather than looking at transfusion at a first choice option for correction of anemia? Okay, so that is actually one of the concerns that blood transfusion for many, many years, decades in fact, has been the first choice, the default treatment option for correcting anemia. And there's a huge calling for that practice to change. So we're just going to wait for the poll results on that one.
I'm waiting for, I don't have to wait. I wanted to get to 100, but there we are.
Okay. Sure. No, that's perfect. Okay. So here we go. Yes. So again, it's a very positive response, which is pleasing. So we've got 76% that say yes. They do consider alternate approaches to correcting anemia. 8% say no, and 15% say sometimes. So that's an interesting response rate. It's positive and encouraging as well. I don't know, Prof. Prof. Lo, Prof. Matthew, do you have any comments at this point?
Thank you, Vanita. It is indeed good to hear that most are considering alternatives. I think in the next session, it would be interesting, or maybe in the chat box, it would be interesting to hear what the typical alternatives are that people are considering. So maybe people can comment in the chat box on what sort of alternatives they classically use. And because everybody will probably say iron, let's take anything that you often use other than iron. Let's assume everybody uses iron.
Sure. Perfect. Thank you for that.
Yeah, and Vanita, just in terms of your second question, alternative to correcting anemia, but alternative to blood transfusion also involves considering alternatives to the other components, so alternatives to plasma and or platelets, and of course some other minor components. So I'd also be interested to know about whether people consider alternatives to plasma and platelets.
Sure, absolutely. So please feel free to populate the chat box in terms of your comments. All right. So as we all know, patient blood management, there's been a global call from the World Health Organization for increased awareness and implementation of patient blood management. And it stemmed from the historic overuse and inappropriate use of blood transfusions as well. So patient blood management, this is the global definition. It is a patient-centered, systematic, evidence-based approach to improve patient outcomes. And here, by managing and preserving a patient's own blood while promoting patient safety and empowerment. It's a very inclusive definition, and it's based on the 3 pillars of patient blood management. Does not focus only on surgical patients, but for all patients. It's very patient orientated in terms of doing what's best for individual patients, and it calls for the multidisciplinary collaboration in terms of providing best care for best outcomes in patients. Okay, so we're moving on to this case study. And I want to go through it as quickly as possible so that I do not take up too much of Justin's time as well. So in this particular case, 4 units of red cell concentrates are ordered for patient X in theatre during delivery of her 4th child. So she arrived at the hospital already in labor, and she presented with an HB of 8 grams per deciliter. So we're going to look at firstly ABO and RH blood grouping results. Remember, every investigation starts with ABO and RH. So if we look at this particular case, I'm sure some of you can interpret it, but I'm going to take you through it very quickly. So we're getting a positive reaction with anti-A. Remember, antigen-antibody reactions are specific. Anti-A can only react with A antigen. So here we can see a positive reaction with anti-A. That means the patient has A antigen. No B antigen, because there's a negative reaction with anti-B. Confirming the presence of A antigen, anti-A, B shows us that. In the reverse grouping, we can see this particular individual lacks B antigen, and we can see the patient has anti-B in their plasma with that positive reaction with B cells. So quite clearly, we can see this patient is group A, and our reaction with anti-D is a 4+. That means there is D antigen present on the red cells of this individual. So we can confirm this patient as being a blood group A positive. If we look at the antibody screen results, we can see no reaction taking place. So the patient does not have any irregular antibodies. Okay, so then we select units for cross-match, and we've selected 4 units of group A, RH positive units. As you can see with the grouping, it matches the blood group interpretation, so all good there. So 4 units of group A positive units selected for a group A patient. Okay, so pre-transfusion cross-match results. So we've got all 4 units here. If we look at the saline cross-match, the immediate spin or the room temperature cross-match, are we getting a negative reaction? That means all of these units are compatible. If we look at the antiglobulin phase cross-match, this is 37-degree cross-match. Once we incubate and wash, these are all negative as well. So all of these units appear to be compatible. So it's good to go. So what happens then? 2 units of blood are collected from the blood bank, and 1 unit is transfused to patient X. 2 hours later, the blood bank receives a blood specimen, a urine sample, and an empty blood bag labeled with patient X's details for transfusion reaction investigation. So the blood specimen shows hemolysis. The urine is dark in color. The doctor reported that immediately after transfusion of the first unit of blood, patient X experienced a hypotensive episode followed by DIC and acute kidney injury. The patient later demised. So it's an unfortunate case. So we in the blood bank, we're looking at the post-transfusion testing and interpretation of results. So here we see in the post-transfusion specimen test results, things don't look as clear as they looked initially when we performed our pre-transfusion test. So here, looking at the blood group, previously it was a beautiful 4 reaction here with the anti-A and with the anti-A, B. Now we can see a reaction of 1, and we've got this MF, which means mixed field. Mixed field reaction is actually an indicator of 2 cell populations in 1 cell mixture. So we've got a mixed field reaction, so that means there's 2 cell populations here. In our reverse grouping, so here we have the plasma of the patient being tested against group A1 cells. That's our known reagent cells, and we can see lysis in that reaction. The RH type of the patient is fine. So it appears that this blood group is no longer a group A as we initially had detected in the pre-transfusion testing. It appears to be another blood group. And if I look here, looking at the reverse group, we're getting a positive reaction with our A cells and B cells. Usually we get a positive reaction with A cells and B cells with the group O individual. Here it's positive, but showing lysis. All right, if we look at our screen results, we can see that there's no irregular antibodies in the patient's serum. We look at the post-transfusion cross-match results now. We can see with the saline cross-match, we're seeing lysis with the first transfused unit. In the IAT cross-match, that's our 37-degree cross-match, there are no cells left after washing. That's because of the hemolysis. We're unable to see a reaction here. Pre-transfusion, the patient tested negative with the direct antiglobulin test. However, post-transfusion, we can see the patient is presenting with a positive DAT result. Remember, one of the causes of a positive DAT result is an incompatible blood transfusion. Okay, so here we can see that we have a problem. The blood has been incompatible. It doesn't make sense because the patient was correctly grouped and screened and cross-matched. If we look at the antibody identification, we're doing it just as a precaution. We know that the patient's screens are negative, so we should not find any irregular antibodies. And this panel shows us that the patient is not presenting with any irregular antibodies in terms of these particular blood group systems. So when we see this type of circumstances, usually if we're not getting a clinically significant antibody from these blood group systems that is causing an incompatibility, immediately we consider the possibility of ABO being the problem. So if we look at this particular case study and if we had to analyze the results, if we had to summarize it, we can see pre-transfusion, the patient tested quite nicely as a group A positive. There were no irregular antibodies. We selected group A units of blood for transfusion and all units were compatible. Okay, so all was well and good to go. However, post-transfusion, we can see we're unable to clearly conclude the blood group. We're seeing the mixed field reaction, the two cell populations, obviously two blood groups in one sample. Here, as I said, the sample appears to be a blood group O, and there is the presence of some group A cells. We're seeing that in the mixed field reaction. The RH type is fine. The antibody screen is negative. The patient doesn't have any of those other blood group system antibodies. Pre-transfusion, patient is unsensitized. Post-transfusion, the patient is sensitized. Cross-match results, we can see pre-transfusion, all was well. Post-transfusion, we're seeing an incompatibility and lysis. So the question I'm going to ask you in this poll, could this transfusion reaction have been prevented? What is your view? All right, just a few minutes to see what sort of response we get here. Oops, let's wrap it up quickly now. Right, we've got 188 participants. Okay, so 41% say yes, we could have prevented this transfusion reaction. 29% say no, we could not. And 29% say maybe we could have prevented this reaction. Okay, so if the simple answer from me is that yes, this reaction could very easily have been prevented. And the reason for that is quite simple, because this is a classical case of an acute hemolytic reaction due to an ABO incompatible transfusion. Now, if we look at these ABO incompatible transfusion, usually the biggest cause of it, the primary cause in most situations, even globally, the literature will tell you is that the clerical errors are in fact the causes of such reactions in patients. So in this case, we had a group A patient that was appeared to be a group A patient that was in fact transfused with group A blood, but the patient was in fact a blood group O. So we have a case of misidentification here. So where did the misidentification take place? It could have taken place at the time of phlebotomy. So when the sample was being collected from the patient to send through to the blood bank. Alternatively, The misidentification could have taken place at the time of transfusion at the bedside. Blood was issued by the blood bank, and no proper patient identification was done prior to administering the transfusion. Alternatively, there could have been some clerical mix-up that could have taken place in the blood bank. Okay, so clerical errors, as I mentioned, is the biggest cause of this type of reaction, and it should actually be prevented under all circumstances because the consequences of such reactions are extremely huge. So ABO incompatible red cell transfusions, they can be fatal, as it has been in this particular case. Its prevention is key. Anti-A and anti-B in the recipient's plasma, these are naturally occurring antibodies. That means if you're a blood group A, you naturally have your anti-B ready and waiting. If you get a transfusion of a group B unit, those antibodies are there to immediately respond to the incompatible transfusion. Also, if we look at the ABO blood group system, they complement binding, and most often they activate the complement cascade right up to the last phase, the membrane attack phase, and this causes your rupturing of your red cells, causing intravascular hemolysis, and we get all sorts of complications associated with that can actually cause extreme adversities in the patients. So this was an interesting picture I found, and I thought it's really interesting and I should share. So it says, did you know if you receive a blood transfusion and somehow end up getting the wrong blood type, one of the ways you'll know, aside from the fevers, chill, nausea, and chest pain, is by experiencing what doctors describe as a strong feeling that something bad is about to happen. And in this case, you'd be right. So even if you look at a lot of cases, you'd say a patient getting an incompatible transfusion, the statement that they use is a feeling of impending doom. And that is probably what happened in this particular case, and it's not appropriate for any patient. Okay, the code seems to be coming up. So this is my last slide. This case and patient blood management, what is the relationship? So we know that postpartum hemorrhage, it is the leading cause of maternal mortality in low-income countries, low and middle-income countries, and it is the primary cause of nearly 1/4 of all maternal deaths globally. And we know that anemia affects almost 2/3 of the world's population, and anemia is associated with severe maternal morbidity. It is an indirect cause of maternal death across pregnant populations in both low-income and high-income settings. And if we look at PBM Pillar 1, which is early anemia detection and management, it is actually a solution to addressing anemia early in pregnancy, avoiding patients being anemic at the time of delivery and not having the margin of reserves to protect them should massive bleeding occur. So that is why early screening, detection, and correction of anemia is key to preventing morbidity and mortality in women and children. Okay, in summary, we know that transfusions are life-saving, but decision-making should be evidence-based, and it's really important that transfusions are clinically appropriate. And if we do have to transfuse patients, it is essential that checking procedures be performed every step of the way, and never ever assume that somebody else has done the checking. Checking must be done because it could actually be the factor that saves a life or compromises a life. Thank you very much for listening to me this afternoon. I apologize if I went off a little bit in terms of time, but yes, thank you very much again.
Thank you very much, Vanitha. That was wonderful. And just to let you know that there were a few quite relevant questions that were placed in the chat box, and I think we have just a few minutes to run through them. For starters, we had a question from Jacques Malherbe that wanted just clarification of what you mean by a weak A. If you could just explain to us what a weak A antigen is?
Okay, sure, absolutely. So if we look at the ABO blood group system, within certain blood groups like the A, we have subgroups. So we have the A1 individuals, we have the A2 individuals, and we have the weak A individuals. So what happens is that depending on the expression or the amount of antigen that you have on your red cell, that determines your classification of group A. So a weak A individual is in fact a group A person. However, they just have a weak expression of A antigens on their red cells. So in those particular cases, we from a safety perspective, we give them the safest possible transfusion. So we would not give them a group A1 transfusion. We give them a group O transfusion. Talking about A1s and A2s again, that is also a different classification. It can become a lecture, but they are in fact subgroups within blood groups, and that is basically what weak A is all about. Similarly, we have the weak D type, again, Rh positive individuals, but having a weaker expression of the D antigen on their red cells. I hope that answers the question.
Yeah, thank you. That's very, very helpful. So then, Vinitha, we had a second question from Deborah Vaz van der Riet. I hope I pronounced her name correctly, which has quite a lot of relevance to those working in smaller hospitals and with smaller blood banks. So her question is, how many investigations do smaller blood bank branches do to exclude alloantibodies in an autoimmune hemolytic anemia patient? Do they all perform autoadsorption at least? She's had blood banks refuse to supply blood to these patients because all red cell antigen panels show agglutination. Should they not be actively excluding auto from allo before refusing blood? So this, I guess, gets to the question that you touched on, which is how to manage blood transfusion needs in people with autoantibodies.
Yeah, sure. So what happens is that when we get any cross-match request in a blood bank, we can only do a certain array of tests. So there's routine tests, as I said, we do the ABO, the RH, the screen. If the screens come up positive and we're having challenges finding compatible blood, the blood bank has only a certain amount of resources in terms of how much of testing they can do. So as a result of that, we have specialized laboratories. We have our reference laboratories. So in those particular cases, when we suspect antibodies to high frequency antigens, autoimmune cases, or incompatibilities where we know we're not going to resolve in the blood bank, these particular samples are sent to our reference laboratories. So in those laboratories, they would do a whole host of tests, and they would do the autoabsorptions, they would do the screening to determine the presence of underlying alloantibodies that need to be excluded, and they would ultimately make the final decision in terms of how suitable the least compatible units are if we had to issue weak incompatible units for transfusion. So that is exactly how it would work. So yes, you would have delays in those situations, and one has to understand that a blood bank itself does have limitations in terms of resources, and it's not possible for a blood bank to do all sorts of testing for cases that are few and far between, because these are not cases that we deal with on a daily basis. So we leave the specialists to handle those cases. I hope that responds to the question.
Thanks very much. And we do have about another 5 minutes or so before we ask Dr. du Toit to speak, and just want to see if there are any other questions from anyone else. You can either chat, or if you can, you can put your hand up and we can use the mic.
Can I quickly ask a question?
So maybe, go ahead.
So, Vinitha, I was just wondering, so I've got a patient now, so in autoimmune hemolysis, so she's got profound autoimmune hemolysis. So she arrived with a hemoglobin of 4, and an LDH of 1,500. I just want to know, so now the blood bank contacts you, obviously they struggle with, finding compatible units. So then they say, okay, now would you prefer the least incompatible unit? My question to you is, we know that these antibodies can hide alloantibodies, but what are the chances of, transfusing an ABO incompatible unit in a patient with autoimmune hemolysis?
So if I look at that particular question, I do not see the possibility of ABO incompatibility presenting as a problem in terms of an ABO incompatible transfusion. The reason I say that is that if we look at a patient where we receive a sample and for whatever reason we are having challenges in interpreting the blood group of the patient, in that particular case, our safest option is to give group O, RH compatible, or in that case, if we do not know the RH as well, group O, RH negative, low titer blood. So in case of doubt, that is the rule that we have in place in the best interest and safety of the patient. Also now with our testing, apart from us just doing this serological testing and workup on the patients, we also do molecular gene screening and typing. We have that as part of our reference facility. So usually when we say that this is the only route that one can take in terms of issuing weak incompatible blood, that is in fact the only option or choice, and nothing more that can actually be offered. So, but ABO certainly would not be a challenge.
Thanks very much, Vinitha. Any other questions?
Just a quick comment. Thank you, Matt. So everybody can see the link there on the screen, hopefully, to the attendance register. You can either control click on the link or use the QR code that you can scan with your phone. And the code that you're going to need is 56 once you are inside. So if you could just have a look at that. Sorry, just see that you got, can you see that? And then just a quick comment on the case. Thank you, Vinitha. What a great case. And we often think that these are unusual cases, but if you look at the data from the United States, for instance, the most common cause of death from a blood transfusion can be linked back to clerical errors and incompatible transfusions due to mistakes made. So that checking of the patient's identity and the blood and making sure everything is perfect is not a step that one can take a shortcut with. That is by far the most important cause of death. And I think when I way back with my PhD, I had to study this, and I think there were over 500 cases in the USA alone in a relatively short period of time of patients who died from clerical errors. Back to you, Matthew.
Thanks very much. Okay, that was a sobering reminder, Brendan. Thank you very much. I think we should move on to Justin's talk, because I think there's a nice linkage here. Hopefully you're all primed to the idea that before you prescribe any form of blood product, you need to have considered the indication and the necessity very carefully. You've looked at alternatives, and that patient, or at least that patient's family members, have been counseled about the rationale for the blood. So looking at this question of, does this patient really need the blood? I'm going to turn this over to Justin Dutoy. I think everyone knows Justin very well. He's a well-established hematologist based at the Wits Donald Gordon Center and has a major interest in hematological malignancy and stem cell transplant, of course, none of which can exist without blood transfusion support. So Justin, thank you very much, and please take over.
Geez, thanks, Matt, for that kind introduction. So guys, I just wanted to actually present to you, I think Prof. Lowe said that I'm going to present some data, but I'm actually going to today present the link in order to create the data. So it's a first on the deep dive. So I hope it's going to work. So we'll see. So I would like to just briefly discuss what the survey is going to be about. So we want to look at red cell and platelet transfusion support and modifications in the in hemato-oncology. And I think Vinitha explained very well, about the concept of patient blood management. And obviously there's a huge paradigm shift that we're all aware of about patient blood management. And it's a very important concept to follow these days, because obviously it's not just centered on a specific pathology or procedure. It's not centered on a specific discipline or sector of medicine. It is aimed at managing a resource like the patient's own blood, and it is aimed at shifting attention from blood components to the actual patient. And it contains all these different pillars. So firstly, to optimize red cell mass by treating anemia, and the second pillar by minimizing blood loss and bleeding, and the third pillar by harnessing and optimizing physiological reserve of anemia. And it's a multi-professional, multi-model, evidence-based approach that can improve patient outcomes whilst reducing healthcare costs. So it's a really win-win situation and a no-brainer when it comes to patient blood management. Of course, other concerns, and Vinitha has discussed this beautiful case vignette that shows you all the negative things that can happen when you transfuse blood. Apart from the financial toxicity, there's other problems like the transfusion of blood-borne diseases, HIV, hepatitis B, hepatitis C, certain transfusion reactions like febrile reactions or transfusion-associated circulatory overload or acute lung injury, alloimmunization, transfusion-associated immune modulation, even transfusion-associated graft-versus-host disease, secondary iron overload, and then, of course, transfusion errors like this case, which can be fatal in the case of ABO-compatible transfusions. Now, what about our field of hemato-oncology? So transfusion support is quite frequent. That's because we use quite intense induction chemotherapies. We perform a lot of autologous and allogeneic bone marrow transplants. That leads to profound bone marrow suppression, and of course, by default, a higher transfusion requirement. But the biggest question still remains: can we apply restrictive red cell and platelet transfusions, for that matter, support in hemato-oncology specifically? Okay, so I'm just going to briefly go through some data on this. So in 2016, there was a systematic review or meta-analysis, and this was published by our Dutch colleagues, Marleen Hoeks in Amsterdam, or St. Queen, the blood bank there. And what they showed was, this is a forest plot. Unfortunately, it was only 4 observational studies and 1 randomized controlled trial with relatively low numbers, where they showed that a lower mortality actually favors a restrictive strategy, and that's specifically in hemato-oncology patients. So their data suggested that restrictive strategy does not have a negative impact on mortality. Although this data it does have a very wide confidence interval, so it's not excellent quality evidence. Then in 2017, there was this Cochrane review, and unfortunately, our answers are still not 100% clear. This review was based on 4 different studies. They obviously excluded many based on the poor quality of the studies. And then they focused on 240 participants. And what they showed was low quality evidence that a restrictive transfusion policy reduces the number of red cell transfusions per patient or participant. And there is low quality evidence that a restrictive red cell transfusion policy has little or no effect on the mortality at day 30 to 100, bleeding episodes, or even a hospital stay. And this was mainly based on patients with acute leukemia receiving intense chemotherapy. And then lastly, the largest randomized controlled trial to date in transplant. This is the TRIST trial. So I think Matthew also showed this data last week by a colleague, Jason Tay in Calgary. And they actually looked at restrictive versus liberal strategies of transfusion. Restrictive was 70 grams per liter versus 90. And what they showed was that there was no difference in the day 100 mortality, also no differences in acute graft versus host disease rates, and even no differences in bleeding risk scores. And more importantly, they had a health-related quality of life questionnaire based on the FACT BMT scores, which actually favored a restrictive strategy. So the conclusion was that in patients undergoing stem cell transplantation, the use of a restrictive strategy with a threshold of 70 grams per liter was as effective as a threshold of 90 grams per liter. And it resulted in similar quality of life scores and the transplantation outcomes and similar transplantation outcomes with fewer transfusions. So that brings us to the current study that I would like to perform. So the aim is to determine our red cell and platelet transfusion practice and modification requests. So modification requests can be whether you request a single donor or pooled platelets, whether you request leukodepleted or non-leukodepleted, and even irradiated blood products, okay, in patients with hematological malignancies undergoing intense chemotherapy, and or stem cell transplantation. That can be autologous or allogeneic. And the objectives of this project is to understand what clinical providers actually do. So is it restrictive versus liberal red cell transfusion practices? And then also to assess, are there any knowledge gaps in terms of looking at red cell and platelet transfusion modification practice for the different hematology patients, and also to assess whether platelet transfusion thresholds for patients undergoing procedures. So having said that, I'm going to share this link with you now on the deep dive chat. Let me quickly share it with you guys. And then I hope that you guys would be happy to participate in this research questionnaire study. What I will do is, I won't have the answers now, but what we can do is maybe present the data at another session, because I think it's very important that you guys also see what came out of this. And this questionnaire is not long, it's about 10 minutes. So I would really appreciate your time to do this.
Justin, I think we may have lost you. I think you were on mute.
Oh, okay. Where did you lose me? Tell me.
Matthew, it might be on your side. From my side, I think Justin was there all the time. Maybe if somebody else lost Justin, just speak up and then we can quickly ask him to repeat. Maybe you could just repeat at least for Matthew's sake, because there might be others, Justin.
No problem. I just want to paste this link in the meantime. There we go. Okay, so what I was trying to say is that I'm going to quickly share my screen again. So I don't know where I should start again, but I'll just say that I would like everyone to click on the link in order to share their experience with transfusion. And this is to understand what clinical providers do in terms of restrictive versus liberal red cell transfusions, and to assess if there's any knowledge gaps in terms of modification practice, and also the platelet transfusion thresholds for patients undergoing procedures. So this link I'm going to share with you guys, you must click on the link. It takes about 10 minutes to complete. And I would be really grateful if you can fill that out for me. And then I would present the data at another session in the future. And that's about it. Thank you.
Thanks, Justin. I just want to reinforce the importance of this sort of survey, because not only are you asking for a reflection of current practice trends, accounting for the data that you showed and other data, but as you know, most of these, if not all of the randomized controlled trials about transfusion thresholds come from Europe and North America, and Australia to some extent. So how much of that is usable in the African setting and South African setting is uncertain. And those who prescribe blood and blood products might have distinct rationale as to why things should be done differently in South Africa. So it may actually be trigger and rationale for separate and distinct clinical trials in your setting, rather than having to adopt the data that comes out of very, very different healthcare sectors and sometimes very different types of patients in North America and Europe. So I think this is very important, Justin.
Thank you, Matt. I mean, if I look at most of the data, I mean, it's been in the critical care, surgical kind of setting. But if you look at hemato-oncology per se, there's very little data available. And if there is, it's low quality evidence, but very important.
Yes, just a thank you from my side as well, Justin. I think this is really, really important and great. And thank you in advance to everyone who is taking part. By taking part, you are also giving informed consent for Justin to present and publish this in future. Obviously, anonymously, your name will remain anonymous. But thank you very much for contributing. Good. I think, Matthew, we could probably close and then let everybody complete the questionnaire on the side. I've just been busy doing it while listening. It really goes very, very quickly. So it might even be less than 10 minutes. So, but I think we can then close on our side here.
Yeah, thank you very much, Vernon. Thanks especially to the two speakers, Vinitha and Justin. In the background is Gerdin, who does all of the hard administrative work to get these sessions moving. And of course, a large amount of the brain power behind Deep Dive comes from Dr. Estelle Verberg. And also to Melanie Davids. Thank you very much to all three of you for organizing these meetings, which makes chairing extremely easy. And thanks to all who've attended.
Yes, and thank you, Matthew, from my side for your great chairmanship, Benita and Justin for your excellent talks and also innovations here. It's been a historical day. It's the first time we did a real-time research-based survey on the Deep Dive, and it's also, I think, the first time, as far as I know, that we reached 193 participants, unless it happened when I was not around. So that is exciting. So I wish you all the best. And next week, we're going to speak about another important topic, super warfarin toxicity. And we look forward to seeing everyone back here. Thanks very much and have a lovely day, afternoon or evening.